everyone. We are so happy that you can join us today. My name is Megan Ivankovich, and I am the Senior Learning Director of the USAID-funded Momentum Knowledge Accelerator, and also a Program Director with Population Reference Bureau, or PRB. Today's webinar is hosted by the Momentum Monitoring and Evaluation, Innovation and Learning Working Group. As many of you may know, Momentum is USAID's flagship suite of integrated projects that work alongside governments, private and civil society organizations, and other stakeholders to accelerate improvements in maternal, newborn, and child health, nutrition, and voluntary family planning and reproductive health. Using a more targeted, context-specific approach, Momentum works to strengthen the capacity of myriad stakeholders to create demand for, deliver, scale up, and sustain quality evidence-based interventions. The Momentum Meal Working Group serves as a platform for collaboration and discussion that brings together leaders in measurement, innovation, and learning from across Momentum, tapping into expertise from external partners and other working groups as needed. We aim to provide technical guidance, build consensus, and routinely review what to measure and different approaches for measurement, analytics, and visualization, learning, and innovation for use across Momentum, thus strengthening measurement and learning across all projects. I co-lead this working group with my colleague, Samia Alva, the Senior MEL Director for Momentum Knowledge Accelerator and a Senior Research Monitoring and Evaluation Advisor with the Center for Health Information Monitoring and Evaluation at JSI. Today, we are very lucky to have Joseph Valadez introduce us to classic lot quality assurance sampling. LQAS is a classification method for evaluating a program to determine whether a coverage threshold has been reached. Usually, this requires a small sample. It's a relatively rapid and inexpensive approach to data collection in lieu of traditional surveys. LQAS is now used internationally and recently integrated with cluster sampling for applications in large countries. During this webinar, we will learn about the origins of LQAS in the 1920s and why it was developed, how to apply LQAS for monitoring and evaluating programs, how to select an LQAS sample size, collect the data and interpret it, and common pitfalls and things to avoid. We know that some of you have used LQAS in your own work, and you have your own lessons to share. Following Dr. Valadez's presentation, my colleague, Dr. Alva, will facilitate a discussion so we can learn from each other about our collective experiences applying the methodology. Joseph Valadez is Professor of Global Health at the Liverpool School of Tropical Medicine, a community epidemiologist who has worked in more than 50 countries throughout Africa, Latin America, and South, Central, and East Asia. Dr. Valadez has supported a wide range of institutions to plan and manage national and subnational health programs. He has advanced the development of rapid and practical program monitoring and evaluation techniques. And most notably for our discussion today, he pioneered LQAS in the mid-1980s while a member of the Harvard faculty. So to inform our discussion today, we wanted to gauge your familiarity with LQAS. So we're going to launch a poll now. So please let us know how familiar you are with LQAS by answering the one-question survey that should pop up on your screen. So how familiar are you with LQAS? Never heard of it? You know the basics, but never used it. You used it, you want to learn more, or you are an expert. So we'll give you just a couple of seconds to complete that. Wonderful. So it looks like some results are still coming in, but it looks like we have about 9% who have never heard of it, a good 62%, 63% that know the basics but have never used LQAS. About a quarter of you have used it, but you want to learn more, and we do have 4% experts, so that's great. So before we get started, I did want to go over a couple of housekeeping points. If you haven't already done so, please introduce yourself in the chat. And please be sure to keep your computers and your phones on mute. For bandwidth issues with people joining from different locations, it would be good if all attendees could turn off video and stay off camera. However, please feel free to turn your camera on during the discussion if you're asking or responding to a question. This webinar will be recorded, and after the webinar, we will post the recording on the Momentum YouTube site and share it with all participants. And finally, throughout the webinar, you can ask questions using the Q&A function in Zoom, but please do not add questions to the chat. You will be able to see everyone's questions and even upvote or like other people's questions that you want answered. So we will be collating all questions and do our best to answer all questions by the end of the webinar. So with that, I'll turn things over to Dr. Valadez.
Oh, thank you, Megan and Sumi. I appreciate it very much. I wanted to thank USAID and the Momentum Meal Working Group just in large for inviting me here and to give this discussion to you of practical LQAS and give you an introduction to it. But let me begin, as I always do, with my learning objectives. Uh, we're going to have an in-depth look at what LQAS is used for and what it's not used for, and address questions such as when to use it, who uses it, why use it, and how to use it. In order to move this forward, I like placing myself in a very practical context. I have a problem. I'm a program manager. I'm managing a malaria program in Uganda. And my activities are that the population should be protected by an LLIN. People with fever should be tested for malaria and told the results within 24 hours of the onset of symptoms. And positive cases should be treated with an appropriate antimalarial. Now, I'm not working across the country. I'm working only in some of the districts, and those are the ones that have the colored discs here. I'm working through district management teams who are implementing this program. So what is the utility of LQAS in this program? Well, in order to answer that, let us look, step back for a second. We know that we need information about program activities for management purposes and other purposes, but at what level should we obtain it? National level data is very valuable, especially for policy purposes, national budgeting, for international discussions, for sharing with the World Bank if a loan is being negotiated, and the like. But at the district level, the people who are managing programs are interested in what is the condition of their programs. They want data relevant to where they work, and they implement through teams as well. Those are the sub-district teams who are interested in the status of their programs. Let's step back and look at this straw man, which I'm setting up for us to advance our discussion. I have a catchment area X. Let's assume it's a region of a country which is comprised of districts. And I've carried out a survey, and in this catchment area, measles vaccination coverage is 68.4%, and you see the 95% confidence interval. How do I interpret that number? Well, I can't really interpret it very well unless I have a target to compare it against. Now, the target is 70% in this program. How do I interpret that? Well, it depends on how, if you take into account the 95% confidence interval, potentially I've crossed it, potentially I haven't, but I may be near it. So I might assume that my program is on the right track by using that measure of the average condition. But let me take a look down at the district level and see the condition here. And I find that there's a substantial variation. And I find that there are 4 districts in particular that are colored blue that have very low coverage, and those that are in the middle area, which are orange, and those that are high. Now, if I just measure or make decisions based on that average, it's very possible that I will leave those areas undetected, and these are going to be the locations where there's going to be potentially be outbreaks. You see, the point of this is that the average masks the variation. And in order to manage a program well, you really need to be able to detect the variation. These districts, in fact, all of the districts are what we call supervision areas, just part of our jargon for talking about this level of assessment. Why LQAS? Well, the question implied by the examples I've just given you is how to assess performance in multiple locations that are delivering the services. And also to tell me the status of my program as a whole and to do it recurrently. I want to have data I can use for two purposes. I want to manage the local production of the health services, and I want data that senior managers can use for high-level decision-making and reporting purposes. LQAS was developed to address these two purposes. LQAS is a classification method. Now, it's not a sampling method, it's a classification method that uses random sampling and is used locally in supervision areas or production units, which brings us back to the production of industrial production of the 1920s when it was developed by Dodge and Romig. And have a wonderful set of papers from the 1920s, which you can see in their 1950 collection. The insight that was stumbled upon at that time in the 1920s was that to control industrial production, that if quality went below a certain level, consumers would stop buying my product, and they would buy someone else's product instead. But if I was able to maintain that level, then they would continue having loyalty to my product. So I really didn't need to have a measure of the coverage or the prevalence of quality. I just really needed to know whether the threshold of quality had been reached and is being maintained. Now, the insight, which was based on a reasonably complicated statistic at that time, produced another insight. This technique had to be used in all the factories individually of the enterprise. And individuals like these two gentlemen that you see here were using these tools. So the tools had to be simple enough that they could use and then understand the results in order to manage the quality in their factory. Now that is a lesson that we've carried over to today with the support of USAID and other donors. It's used in supervision areas to identify the priority production units, not reaching an established performance target for coverage with the medication or vaccination or voluntary counseling and testing or whatever it happens to be. At what level? It will depend on how you define the production unit. That could be a district, a county, a sub-district, could be a catchment area for an activity, could be a refugee camp, or a portion of a refugee camp, or the NGO catchment area, for example. That data is useful for local management decision-making in those supervision areas and can be used to maintain quality. When that is done, the data can be aggregated and measure average coverage at a more central level, be that a region, provincial, or even national if you have the data. That is suitable for reporting and policy purposes. The attractiveness of LQAS is that normally it uses small samples, and we'll get into that right now. Now, in order to use LQAS, we need to not reinvent the wheel. We need decentralized management tools. And I'll give you a set of URLs to link you to those tools as we go through our talk today. I have here two sets of videos. The one on the left was commissioned by FCDO to be a promo for LQAS, so there would be a rapid introduction to ministries of health and other donors and stakeholders in nations, and then was supported by USAID as well. It's 8 minutes, and that has discussions by, in fact, it begins with the USAID representative in Uganda, moves over to individuals who run the health system in India. World Bank is included, UNICEF is represented, but the voices of interest to me really are the district health managers. And they have wonderful insights, which I encourage you invest 8 minutes of your life to see that video. The other two on the right-hand portion of the screen are training videos, which were made with the support of US aid for, for Africa and for South Asia. It's a very same script, but for these two different contexts with different visuals. In the first chapter, I encourage you to see. It's a wonderful overview of LQAS. It's 3 minutes long. Let's move to an example in Nepal. This is Ratahat district in the Terai. It has 7 field areas. LQAS was used here to classify these areas into 2 pots. Those that are classified as reaching the target, and those that are classified as below the target or below average coverage. I use this slide to emphasize that LQAS is a screen. I use that concept of a screen because it's a term that people at high levels in ministries of health understand because they come from medical professions typically, and they've all used screens in their professional lives. So they feel empowered and they understand what we're trying to do, or what their teams are going to be doing by using that term. Now, once you have those areas that are identified as below average or below target, then you can consolidate them and investigate reasons for program problems there, where they exist, or they're likely to exist. Those that are classified as reaching the target, you maintain the programs moving forward while you can invest your scarce time and energy into problem solving down below. But also, you can identify strategies and tactics that have worked in those successful areas, which can be lessons learned for those that were problematic. But we've also found that those supervisors and health workers who were successful in their areas can actually be very good at problem solving in those areas that have had the problems. And the dialogue sometimes is very welcomed by the other health workers. LQAS works in this example is by dividing an area into 4 or more supervision areas but it has to be based on how services are delivered. You're always controlling a production unit of some sort. Then you train the local health staff to randomly sample, well, in our example, 19 respondents randomly in each supervision area. That's a typical sample size. In the global review by World Bank and WHO in Social Science and Medicine in 2006, 800 applications were reviewed, and the most common sample size was 19. These then can be aggregated as a stratified random sample. So in this example, it would be a stratified random sample of n equals 95, with no meaningful design effects. So it's very powerful data. But how do I choose an LQAS sample size in a decision rule? Well, there's 3 basic steps to choosing a sample size in a decision rule, and they can't really be violated. Set the target or the level of coverage your program is to accomplish, and you want classified correctly if it has reached the target. And we'll have 80% as our coverage target here in this example. Then you identify a lower threshold, defining areas of egregiously low coverage you can't afford to misclassify as acceptable because there's so many people that are at risk. And we'll have 50% coverage in this case. Now, typically, with a sample of 19, the coverage target, or P upper, is about 30 percentage points larger than the lower threshold, P lower, I emphasize for a sample of 19. You can change the range of this threshold if you wish, but there's an implication for sample size. But let's get on with the 3rd step, which is to identify an acceptable classification area for each of these thresholds. And we encourage these error terms to be equal to or less than 0.1. These decisions affect the sample size. Now, I'll emphasize again that P upper and P lower can be set at any level relative to each other, but have to take into account the sample size. LQAS is very sensitive for detecting the worst of the worst and the best of the best. It detects the ends of the distribution very well. At the encouragement of USA in approximately year 2000, in the NGO Networks for Health program in Nicaragua, Malawi, and Armenia, I took the 60 pages of statistical tables that are in my book through Harvard Press, Assessing Child Survival Programs in Developing Countries, published in 1991, to make it a more user-friendly tool, less than 60 pages. So we reduced it to this one page, and I'll show you how it works, and became a valuable tool for people in the field. So your coverage targets are across the top here, ranging from 10 to 95. And there's some sample sizes that are on the left-hand side. We're going to stay with our sample size of 19, but we're going to choose a target of 80. And you put your finger there, and then on what your sample size is, 19, and where they meet is a decision rule. That means if you've reached the decision rule, 13 in this case, you're able to classify the supervision area where it was collected as having reached the target of interest. If it was 50%, you do the same here and where they meet. 7 is the decision rule in this case. Now, people feel they can use this tool and feel empowered. They can use it recurrently. Now, why 19? Why not any other sample size? Well, if you look at these cells, you will see they're white, blue, and yellow. Those colors have a meaning. If they're white, it simply means that the alpha and beta errors are less than or equal to 0.1. If they're blue, that means that alpha or beta or both are larger than 0.1. If they're yellow, that means that alpha or beta or both are larger than 0.15. Now we've been very rigorous in setting this up, and it also assumes that the P lower is 30 percentage points from P upper. This is the link to my book I was asked to include, and it's available through Harvard Press, Amazon, Barnes and Noble, and Waterstone, depending on where you are. I'm just listing the summary of steps to collect the data in the field, but many of you are very experienced in data collection in the field, and that's not the purpose of this talk. We don't have enough time anyway. I just listed 7 to consider after defining the supervision area and the catchment area and the client's population of interest and the age group and the key indicators and targets. You can use probability proportional to size to identify the interview locations, and normally these are villages. Then use segmentation sampling to select the starting household. And at the starting household, identify an eligible interviewee using simple random sample if that's necessary, if there's more than one eligible in the household. You can then use the LQAS table to classify each supervision area and aggregate the data to measure the prevalence. Now, how large a sample do you need? Well, it depends on resources you have and on what the question is that you're asking. When I was working in Kangemi slums in Nairobi some years ago, I wanted to use the smallest sample size possible, the 19, in order to maintain the positive attitude of my data collectors working in this very difficult location. In Nepal, there were environmental constraints that really motivated us to keep these samples to the minimum needed to answer the question. And as you can see here, there can be just remarkable impediments, including these boiling rivers, such as the one you see here in this slide. This is a picture from one of our wonderful data collectors in South Sudan during the rainy season, as we were carrying out the national LQAS in 2020 and 2021. The dedication of these guys was just remarkable, and you see him carrying his kit on his shoulder. LQS is a classification method. It's just classified as accepting or acceptable according to this performance target. Why do you do that? The classification is linked to a response. So you can invest resources in where they're needed to rectify problems in areas which have unacceptable coverage and understand what the underlying reasons are for the problem and identify the effective practices in areas where they're acceptable so that you can use those as lessons learned and improve the other areas and share them with other stakeholders. Now, the classification based on a sample from the population, so it's subject to risk of misclassification errors, which we emphasize, just like any other survey is. Data across several essays can be aggregated as a stratified random sample, as I've already said, to calculate coverage for the entire catchment area. Let's look at some pitfalls to avoid and what a sample of 19 can't tell us. It's too imprecise to calculate exact coverage with any precision in a supervision area due to the typically small denominator. Here we have an example of 8/19, which is 47%. And you see the 95% confidence interval of 0.225. It's so wide as to be meaningless or unusable for management purposes. But it is very precise if you aggregate these data to calculate coverage for the entire areas. That was not its original purpose. It's also not sensitive to detect differences in supervision areas that have small differences between them. Don't define a middle band of coverage, sometimes called the yellow area, in the middle and expect the classic form of LQAS to be used to detect it. It's not used for that purpose. My colleagues at Harvard Biostatistics Department, I saw Professor Pagano online with us, who, with his team there, developed multiple classification LQAS. And it's been published in several locations now, and it's used for this purpose. And we have an app that developed for this purpose as well. That's not going to be discussed further in this slide set today. Another pitfall is not training data collectors for the full time, for 4 to 5 days, which is typical, thinking that LQAS doesn't need in-depth training because our data collectors are really experienced, and also it's so easy, it doesn't really need that level of training. Wrong. It always needs training. If you want to have good data, you need good data to have good results. Otherwise, you end up with garbage, and it's not worth the time, and you've wasted all your resources and your time. And worst, you're investing in planning programs based on incorrect data. Another pitfall is not checking the reliability of the data collectors. That is taking a small sample of the questionnaires and going back to see whether the mother has been contacted, exists, been contacted, and responds the same way to those indicators or questions that wouldn't change. Her age, for example, and age of the child. There are several advantages that have become evident by now, I believe, and that you can train the local managers to collect the sample. They can use it for which in the areas, to collect the data in areas that they are responsible for and they know. And because they actually use the data for their purposes, they're very, in my experience, very dedicated to this data collection and will go through tremendous amounts in order to make an effort to collect good data. You saw the South Sudanese data collector, but they know where the villages are, so they can go there. Okay, they don't need a guide, which saves costs. It can be used at a local level with modest amounts of supervision due to the small sample size, assuming data collectors have been well trained and well supervised. It identifies where the successes and challenges are that we've said. And they can rapidly interpret the data, the results, as I'll show you in 1 second. Although we use smart devices these days, paper and pencil analyses can still be used. And it can be used at national level for reporting as well as for local management. But what we like is the sampling theory can be scrutinized. My colleagues at Harvard like to call it a most accurate method because you know what the probabilities are for almost every coverage level you have. Now let's look at real data. This is from Eritrea. This is from Anseba, which is one of the 6 Zoba comprising Eritrea in the time when this was collected. And we're looking at LLIN usage in the previous night by a child. So data collectors in the Ministry of Health in each of the sub-Zobas, which are represented by the numbers in the left-hand column, 1 through 8, to collect data in the areas for which they were responsible and in villages where they know they're located. After each of the 8 teams has done that, they come together and then they tally the results. And once they've tallied the results into yeses and nos in terms of whether they slept under the net or not, they come together and they make this table, which you see here. This is the table that was presented within a few minutes to plenary for them, but also for the Director Generals in the Ministry of Health. Then the question was, using the decision rule, where are your priorities? And as you would, by looking at this, choose one in 4, because they have not reached the decision rule. And Director General did this, of course. They looked at each other, shook their heads up and down and said, they nodded, they can use this. And it has been used recurrently still unto this year. We're still contacted by the Eritreans to provide advice and support, but they have an independent unit doing this. These are the problem supervision areas, and that's where the problems will be solved. Also, you can see accrued coverage statistic, 63.2%. Now, this is the whole country. The north, the 3 Zobas of the north, and 3 Zobas of the south. See if you can see for yourself while I'm chatting what the difference is between the north and the south. Look at the distribution of asterisks. Few in the north, many in the south. Why was that the case? This really sparked discussion in the ministry, and we had a lot of angry director generals at that point. Not with me, mind you, not with me, but existentially upset. And the reason this is the case is because in the northern area, there had been a lot of rain that year, and so the donors were supporting programs in that area, but not in the south. As a result, in the south, they had poor coverage, poor use of nets, I should say. Poor use of nets. Coverage is a different issue. They were concerned because they have seasonal malaria in this country. When the rains return, there'd be major problems. So they emphasized to the health system to improve use in those areas. Let's take a look at the nation as a whole. Here's the distribution of weighted coverages for each of the 6 Zobas. You can see the variation right there. Here's the country as a whole. There's a close friend of mine who likes to say when he sees that none of the regions resemble the average condition. And if you make decisions on that average, you make a decision that isn't relevant to any of the areas. This is the example of the man who fell asleep with his head in the oven and his feet in the freezer, but on average, he's feeling okay. Let's now take a look at Ghana for a moment. We did this with UNICEF and 3 regions in the north. They're large regions. There were multiple indicators. We're just looking at these 5. What's the priority for these? It includes vaccination. If you look at the prevalence measures, it's the north. But let's plow down into the north and see where the variation lies. These are the districts that comprise the north, and here's the raw data for it. I'll aid us out by identifying the priority area based upon those data. It's Central Ganja District that needed this most support, and that's where it's located. Now let's plow down into Central Ganja. This is the supervision area results. I've highlighted with yellow, those are the priorities. But which of these essays is the priority? Well, it's a Kusuagu subdistrict that is, and that's where it's located. And that's where the priority is in that in that district for the health system to work. Now, LQAS can be used over time to track changes. Here's an example from Nicaragua in Hurricane Mitch in 1998. which USAID responded in support of Nicaragua, and the mission asked that we would support the country to recover from that through the NGO Networks for Health program, which is a USAID-supported program. Where we worked with 16 non-governmental organizations at that point. This is in Jinotega Departamento, which are in the mountains bordering Honduras. Due to the hurricane, there was a lot of groundwater contamination, and there's a worry of diarrheal diseases. Therefore, that was one of several priorities. Here are just two indicators. This is baseline data. You see on the right-hand side that mothers who had children with diarrhea in the last two weeks that used ORT, 23%. And then the population of mothers in the age group who knew how to repair it correctly, 41%, both very low and therefore were prioritized for improvement. After 1 year, the teams collected LQAS data again, becoming more and more competent in doing it in their apprenticeship with us. At 38% was the second measure. So there is improvement. There's a lot of movement yet needed, but they're maybe moving in the right direction. But when they look at the preparation skills of mothers, they found there was no change at all. They were very concerned, all of them as a group. Each of them had a different strategy. Each of them was unsuccessful. So they decided to dispose of their strategies and work together to develop a joint strategy, the substance of which is a different discussion. And in the third round of LQS, when they're becoming very competent in using this now, this was the result. Now, not all indicators display this level of improvement, but some indicators can improve rapidly. If you want to learn more about Nicaragua and the work there, we have a new book that's just come out a few days ago, actually, through Routledge Press with Jerry Hagan and Bill Haddon. And it's based on 20 years of work because we've included information and interviews with our colleagues in Nicaragua just in the summer of 2023. If you look in the lower right-hand corner, Michael Quinn Patton reviews the book, and there's his video on YouTube, which I've highlighted in the lower right. I'll end this talk just by referring you to LQAS tools and links. The first one is the LQAS toolkit that UNICEF asked us to develop for them so that their missions and ministries could use this worldwide, and as well as it includes the training manuals. These are in French, English, and Spanish. The toolkit is primarily in English and in French. We also have a Russian training manual as well. The sample size calculator is the next bullet, which you can use to set your P upper and your P lower wherever you wish and see the impact on sample size after you set your error term, as I've discussed it. It's quite simple to use, and it might give you some insights. Large country LQAS is the next bullet down, which is the integration of cluster sampling and LQAS. The paper with the World Bank is published here when I was at the World Bank for much of my career. And then we've also developed an app for its use, which makes it quite easy to use, actually. The last one is GAM LQAS, which was a reduction of the classic LQA, of the 30 by 30 cluster sample into a much smaller LQAS version with a sample size of 144. There's the main paper, but there are several papers that were written on that we wrote on that. So with that, I'll say thank you. This is that part of the discussion. I hand it over to my colleagues. Sumya.
Thank you, Joe. That was a really interesting presentation. A lot of ground to cover on the LQAS in 35 minutes. And thanks for all of those details on the sample size calculator, etc. I'm sure I have a lot of questions because it's a lot to do in 30 minutes. But I'm going to go to some of the questions in the chat. Actually, not in the chat, in the Q&A. And if you have any more, please feel free to add to them. But I'm going to start with what's here. The first question is, are supervision areas similar to low coverage areas?
Good question, thank you. So supervision areas are defined by how the services are delivered. If I have a vaccination squad in an area, that's a production unit. In Nigeria, where we worked, the district, or I should say in that case, the ward, had several, or the LGA had several ward level teams covering with the areas with vaccinations. Those were the supervision areas in that particular case. So supervision areas have high areas of coverage or adequate areas of coverage and lower areas of coverage. They can include both the inadequately covered ones as well as the adequate ones. Depends on whether the results reach the decision rule or not. Next.
Okay. Another question from Augusto Losa. I hope I pronounced the name right. Seems there's a third classification, above 80%, below 50%, and in between. If so, what's the interpretation of the third classification category in terms of, for instance, recommendation to programs?
So LQAS it classifies by either side. And I didn't go into this today because it's too much. There's and if you use the calculator, you'll see this is all laid out very nicely. There's an operating characteristic curve that defines this gray area. And what it will show is that those areas that are near to, but not at either end of the distribution would have a likelihood of being classified as either on the acceptable or the unacceptable side. So if I have real coverage that is near to 80% in the example that I've used, but not at 80%, it will likely be classified as 80%. If it is higher than 50%, but near to 50%, then the likelihood is it will be classified as on the 50% lower side, is rejected. Now, the point being is that you identify the best of the best and the worst of the worst. Those that are low coverage, but not among the worst of the worst, but are classified in that, they do have low coverage, and they would, therefore, if they are identified as priorities and investment is made to improve coverage, that we consider still acceptable. The point is that you're not investing into those that have high coverage. As conditions improve, and the coverage target increases, then those that you have missed will eventually fall into the prioritized area. But you don't necessarily classify those or know which of those are in the gray area using the classic. It's taken care of in terms of the way the probability of classification is depicted in the operating characteristic curve.
Thank you so much. My next question is from Dave Boone, my colleague at JSI. If aggregating results from supervision areas to determine prevalence of a district or region, and you can't assess all the supervision areas in a discrete time period, for example, a month or a quarter, what are the implications for interpretation if the data are collected as a rolling sample over a longer period, for example, over 1 year?
That's really, really good question. Thanks a lot. Well, that's one reason why large country LQAS was developed. And the idea was, like in Kano state, for example, that had 44 LGAs, for example. And we had 7 states to work in. To train and manage teams, and all of those would have been very expensive, incredibly challenging. And the question wasn't necessary to do it all at one go. We needed to have meaningful data for the state level. So large country LQAS answers the question, what's the minimal number of LGAs in that example I needed in order to get an accurate prevalence measure above. And I could tell you how that is undertaken, but let me just make the point. And then I sample in those LGAs or in those districts only as my supervision areas. Okay, and I have an accurate measure above. Now, next time, what I can do, since all of those LGAs that I've taken are randomly sampled, once I know how many I have to sample, I can take another random sample, not using using random sample without replacement to capture other other supervision areas. And by so doing over a period of time, however that's defined, whether it's 1 year or 6 months, for example, you would be able to then have a continually populated map showing the prevalences of these essays or the classifications of these supervision areas with an improved estimate of coverage, which I would expect in a short period of time will not change so much. But you want to have enough data in any one go that that the teams are able to analyze, feedback, and use for decision making so that action can take place. Now, the way the system works is that it's based on how heterogeneous the any given LGA is, and we use the error terms and DHSs in order to drive that, or in mixes to drive that if they happen to be available. And in some locations, like Kano, which had a lot of homogeneity, there were about 12 or 44 that we needed to sample. But in Gombe, which had much more heterogeneity, we had a larger number. I can't recall the exact number, but it was a larger proportion of the LGAs, however. So that's how you would do it. I would use large country LQS first and foremost. That's what I would do. Or there are other strategies, like you could do half of the catchment area in one interval, and then another half in another interval. That's another way of going. It really depends upon the program and needs some more focused discussion, which I'm happy to have with anyone.
Thank you, Joe. There are a few questions here, and I'm going to go through them. But if you have any, we're trying to make this interactive, but it's a little hard with the time. If you have any reactions to this, please feel free to put them in the chat, and we can look at them as well. So the next question is, please explain decision rule.
Okay, sure. Yeah, I went over that quite fast, didn't I? So a decision rule is a statistically determined cutoff point. So if I take a sample of 19 kids and assume my target is 80%, that rule said that once I reach 13, then I can classify the area as having reached the target. Okay, I will classify it that way. And so that simply means as I am analyzing the data, I simply, as I did for Eritrea, identify those areas that have not reached the decision rule to classify them as unacceptable and focus on them for improvement. It's a statistically determined cutoff that is determined using the cumulative probabilities of binomials, which didn't go into here for obvious reasons. It takes a more thoughtful presentation. So it is a cutoff value. Normally, even though you have a cutoff value, you collect all the data. So you can have a good prevalence measure, and also because you're measuring maybe 40 indicators in addition to the one. So some will have succeeded and others not. So you collect all the data. I'm not sure if that's answered it or if I've helped you understand decision rules better.
Yeah, I'm going to go ahead to the next one anyway. Like I said, please put any reactions in the chat. Here's a question on small size LQAS. There's a question about small size LQAS that the polio program uses. Do you have any insights on that? And I'm going to throw another question after this is coming to aggregation for provincial or national coverage, should data be weighted or how?
Okay. Um, so the polio program, I think you're referring to the to USA's polio program. Okay, I think that's the one. Now, I haven't seen reports from that particular program as yet. Um, and so I can't comment on that one, but I would very much like to, because if, for example, it is using this yellow area to classify locations with middle level coverage, that could be a problem. I don't know if that's done or not. I don't know, but I've seen vaccination uh, coverage reports from other programs that have used that report, which I find problematic. So I'm sorry I can't speak specifically, but I'm happy to work with USAID on and discuss with that team happily at any time.
So you have the couple of questions on weighting,
Oh,
on
sorry.
aggregation for provincial or national coverage, and another question related to that. Other than weighting, are there any other methods or processes to be followed?
So normally what we do is we weight by the population size of the sample. And given that we've done probability proportional to size to identify the sampling locations, we have those weights. So those then go into the calculation in the normal manner. But as and we encourage that for anything formal, national reporting, reporting to donors and the like to weight the results. It's a rigorous thing to do, and if that's being done at the central level, it's something that should be done. At the local level, uh, if they're trying to calculate coverage at the local level, then I think accrued coverage proportion may be sufficient. Reporting it as accrued coverage, because you could even see from the case of Eritrea, the difference between the crude and the weighted was about 1%, with 1%. So 1 percentage point, I should say. But it will give you enough information in order to make a program decision, which is what the purpose of it is at a local level. Sumia, what was the last portion of that three-part question?
Well, it was the same thing about, are there any other processes other than weighting that could be used if you're thinking about a larger representative area?
I'm just not sure what's being referred to, quite frankly, in that question. Is I would need greater specificity to that, but weighted
Okay,
coverage, I just can't answer that question.
that's
Sorry.
fine. Let's go to the next one, and this is from Jim Ricker, and he wants to know about LQAS in a health facility, where the facility or a group of facilities would be the supervision area. He also wants to find out whether you can consider either consecutive patients or some other sample based off a client list that could be an adequate estimation of an SRS to be used for LQAS.
Okay, so there's a, hi, Jim. Um, there's an HFA question and there's a community LQAS question at the same
Mhm.
time. That's fine. Let me do the last one easily enough, uh, um, which is sorry, I've lost my thread on something I said. Okay, I can't even read my writing on that last. Would you repeat the last part of that
So
again?
the last part was, it's really patients who are consecutive patients based off a client list. So you have a health facility and you have a client list. Would that be okay? It's not true community, but this is like a client exit interview type thing.
Yeah. Um, I think you've got to be really careful with any list. If you use a client list in a health facility to sample within the community to get a representative sample of the community, then it will only include individuals on the list who attended the health facility. Now, if I did that in South Sudan, my goodness gracious, I would be really underrepresented. If I do that in Northern Uganda, it'd be underrepresented. Okay. Now, if I use a list within the village that even the village chief has, like the tax list or whatever, it really needs to be updated. It needs to be reviewed very, very skeptically, because there's reasons why people are put on lists or excluded from lists due to the favor of the chief for tax purposes, for example. So I'm very skeptical of that, Jim, and I found that segmentation sampling is so easy to use in the field, and you get a good layout of the community by so doing, and involve the leaders in the making of that rough map, which takes about 40 minutes. That it's worthwhile to take the time. I'm just very skeptical of this, but it has been used in areas when it's been updated for the purposes of sampling. The other one has to do with health facility assessments and what's the supervision area. Really, really good question. Well, we haven't had this discussion for many years, but when we use for health facility assessments, we use the hypergeometric rather than the binomial for identifying the number of health facilities to select in order to make a classification of the district. The district becomes the supervision area at that point. And the reason is that often the number of health facilities is few, let's say less than 100, and the hypergeometric would be more robust than the binomial. Now, the LQAS sampling calculator, you can choose binomial, or you can choose, which is the default, or hypergeometric, and then put the number of health facilities that you have in. Now each facility becomes a sampling point. Now, we normally take 6 kids randomly, either as they come in, assuming that there is nothing systematic by the way they come in, or from a random sample of the waiting room if they have the symptoms of interest. And then those 6 kids there's a decision rule for identifying whether the health facility has adequate clinical quality or not, and they're permitted one of those 6 failures. You must have 5 successes. If not, then they're classified as a failed facility. So that's a 0 for that facility for quality. That is, and the reason that decision rule of 1 in a sample of 6 is selected, I can go into if you wished. Then when you have the series of health facilities in the sample, enumerated as 1s and 0s in terms of successes and failures for each of the indicators of interest, you can classify the district as having adequate or inadequate quality of care. That then identifies whether you have a health system problems that can be dealt with through supervision, or is a chronic health problem and needs a more systemic response. That's how we think about it. Jim and I have used it in places in South Sudan. We've used it that way. Actually, the first time we used this in South Sudan in 2015, the minister came to convene the session. He stayed for the entire hour and a half. I couldn't believe it. Never had that happen. And everyone under him, of course, stayed as well. He then required that it be used every time there was going to be an assessment of the facilities. Anyways, that's just a story.
Thanks, Joe. There are a bunch of questions. I'm going to take a couple of questions now and pass them on to you. And maybe what might be better is we can write answers to these questions that we didn't get answered and send it out later, and keep a little time for interactive discussion based on people's experience with the LQAS. So one question I have here is, some people change the target after the data for the 19 sample is collected and try to judge which level of target the observed sample is close to. What do you say about that?
So as I understand what was said or asked, you go into the program, into the exercise by setting a target. Before the data are analyzed, you you decide to calibrate the target differently, and so you do that. Well, you haven't used the data yet in order to make a decision, okay? But I think what you're saying is something else, asking something else, which is, I made one classification and found out I don't have enough variation in my samples. So I want to change it. So generally reducing the coverage target to get more variation. I must say that even though one should only use data once for doing any type of statistical test, in terms of practical LQAS, if you're trying to, it's very difficult to set targets. And once you have the data, and if you would like, especially at baseline, it can be useful to identify what the reasonable target is in order to identify those areas which should be your priorities. Even at baseline, you'll find a lot of heterogeneity, a lot. I would say it's a useful exercise to reduce and begin again, recognizing that you may be on that you're using data twice. However, the point is it's intended to be practical and used for management, and that is a useful management application. So I would say that is arguable and would need to be reported that way also. It just needs to be reported that way. Oh, hang everything out on the clothesline so everyone can see it and discuss it. That's what you need to do. Good question. Thank you.
Yeah, thanks, Joe. The two questions here on how do you identify the 19? Is it conveniently located 19 households? Is it random? What sort of sampling method is involved?
Randomization is critical. And once you train the guys the data collectors, and how to collect a random sample, it's easier than than fudging the data. It really is. So it's a random sample. We use segmentation sampling typically, and there's a wonderful paper that was produced. If anyone wants it, we can send it. And it was also supported by USAID. By the idea is simply this: you make a hand-drawn map with the help of leaders within the community. Okay, using landmarks initially, road, footpath, schools, mosque, church, football pitch, graveyard, big stone, prominent tree, for example. And then what the leaders do, which becomes a nice little debate, they estimate the number of houses that are around each area and enclave. Sometimes, if they're not numerate, as was in the case of northern Uganda, they used stones to indicate the density of the houses and areas. The Ugandans taught me that actually worked really well in non-numerate areas. Based upon that, you then divide segments, and those segments are approximately equal sizes or reasonable sizes, similar sizes. And then you enumerate them. And you select one of them randomly using a random number table, which they're trained to use. And it's quite easy to use. It's less than 30 or less than 20, I like, or less than 15, really. If it's larger than that, then it's separated again into two segments, let's say, and another segment is sample. And when you have enough houses that you can see, you actually draw a mini map with them enumerated and choose one of them randomly. Then you go to that house, and that becomes the reference house. But you don't sample there, because there's a chance that houses were missed on the map. And therefore, we use that as a reference house and go to the next nearest house. And therefore, houses that had zero probability of inclusion are included in the sample, with a higher likelihood of being included in the sample. That's where we start the data collection. The people are then enumerated. We didn't ask about anything about the people, we asked about the houses. So that would be constituted a random sample of the houses. We like that better than the spin the bottle technique for many, many reasons that CDC went into in some of their discussion papers. And we've always used that, and it works like a charm, especially when you have houses and slums that are built on top of each other or in unusual terrain. Let me tell you, or if you're working with apartments as well, as we did in Armenia. Anyways, I think I've answered that question.
Thank you. One last question I have here, and then we'll keep a few minutes for any audience experiences. This question was on patient charts. Can you use LQAS to conduct patient chart reviews at health facilities? I don't know if it's similar to the client exit interview type question that was asked as well.
Oh, no, it's different. The client exit interview is very, very useful for having mothers respond to their assessment of the quality of care. You ask them, did they get the medication? Do they know how to use it? And they tell you how to use it. In most cases, they don't. I have a lot of national studies that show they don't know how to use it because the counseling portion has not been used well. Looking at the medical charge means look at the medical record that is written into at the time of the intervention. Can those be used? We actually have used those in Costa Rica back at the beginning to assess whether if we sampled them, how they compared to a community survey. But mind you, they had very high coverage. So therefore, the records were reasonable representative of the community. They were very similar in terms of the prevalence measures. However, the individuals who had low coverage was very interesting, who said that they had low coverage. When we went to their medical records to look at it, they actually had very high coverage. And many of them who had high coverage actually had very low coverage. So it's not very useful for it. It can be useful, but medical records can be very, very difficult to read. And you can have multiple people reading the same records and they can come up with different interpretations. But it depends, what are you going to use the record for? Is it for a diagnosis? Is it for a medication? What's the purpose of the medical record? Why would you be sampling it? For what purpose? I'm a fan of direct observation. And even though people know that they're being observed, I have the Hawthorne effect working in my favor here. That's the best they can do. And I find that there's problematic behavior. That's problematic behavior. It's going to be there when I'm not there. I hope I didn't skirt around your question, but that's how I understood it.
Thank you. So before we wind up, I know we're past 10 and we lost several people who could stay just for the hour. But I did want to ask if anyone from the audience in the participants want to come off mute and talk about their experiences using LQAS, things they may have done. We just have a few minutes for that, unfortunately. Any volunteers? Let me see if there are any other questions. Otherwise, one question we had was somebody wanted the paper where you talked about the random sample. Do you have a paper on selection of the sample, Joe?
Yes, sure we do.
Sure, we can send that.
In almost every publication we include that. So I can send you a nice sample of them. Happy to do that. And the training manual also.
Okay.
Oh, and it's in the film.
I think we answered several of them. Jim, I don't know if you're still here.
He left in a noted
He
chat.
left. Okay. If the question got answered. I don't know if there's anything else in the chat that came in. Just see. Is LQAS appropriate for DHS or mortality survey in conflict areas? Meaning it's not to supervise intervention coverage.
I can't speak for DHS. DHS has a gold standard that has the benefit of having a methodology that is comparable across time and across locations. Could it be used for aggregate national level measures? Yes, LQAS could be used for that. Should it replace DHS? I'm not arguing for that. I wouldn't argue for that point. That's someone else's decision. But is it accurate? We did a comparison in Southwest Uganda. In fact, I didn't. Harvard Biostatistics did, comparing LQAS results and DHS results, because we had every district in the Southwest sampling domain covered with LQAS at that time. And we found we had very good comparison of results. There are two indicators that did not work well. And one was because of the questions being asked differently in the instrument, but they tracked very well together. That paper is available if you want it. Also, as are papers that show that local data collectors collect as data that is equal quality to disinterested data collectors. We've done that twice, again with USAID support in Uganda, and those are published and available too. That wasn't your question, but I thought I'd mention it since you might be thinking that.
So I'm also looking at the chat to see reactions to questions that you answered. One was regarding the patient list that Jim asked about. So there's a reaction from Adam Richards who said, it could be used to track indicators of care quality among individuals who reach the facility.
Yes,
That's
I'm
okay.
doing so and assuming you can read it.
Yeah.
Assuming the diagnosis was made correctly.
Right. One other comment that was also there regarding the decision rule was, we take a practical example of measles vaccination. If out of 19 kids, you have 13 who've not been vaccinated, then that is a low coverage area. Is that right?
If you have not reached 13, if 80% is the target, that is classified as not reaching the target. So yes, that's how the way the decision rule would work.
Okay. I think we are at time, and I've tried to go through the questions. We may have missed a couple here and there.
Like the
Joe, did you have
polio group,
anything else, please?
I'd like the polio group to send me some reports because I want to answer the question that was asked earlier. So I make that request of my colleagues in the polio.
Yeah, there's a comment on that too. Somebody else said, I believe the colleague's question relating to the polio program's use of LQAS was about GPEI post-vaccination cluster LQAS assessment using 6 clusters by PPS and using 10 homes systematically sampled. So
yes,
that's 6 by 10, which is just small.
That is that firstly, that's not classic LQAS. It's none of the adaptations of LQAS. It's based on a different adaptation of another individual, and it's is based on an assumption that the variation across the districts in which it's being sampled don't exceed a certain amount. Now, in the reports that were published in that group, large numbers of those provinces did exceed that variation, and therefore the premise of the method, which is that it could produce in simulation reliable results, it's been violated, and therefore that there's a real problem with that. There's a real problem with that approach if you want to have accurate results. So I would say my opinion is that it works in simulation, but in field settings, it has problems. And I would be very careful. I would be very careful about using it. I very much would. I wouldn't do it myself.
Okay. Thank you. There are a few other questions that came in, Joe. I think what might be best is if we made a list of these and we could try and answer them and send it along with the recording and the slides for anyone may be interested. So I'm going to wrap this up. We're at time, and thank you so much. We've had a great turnout for this, people from all over, and some really interesting questions and comments in the chat. There's a lot of ground to cover for those who didn't know much about the LQAS, as well as people who have used the LQAS some but needed to find out more. So thanks so much again. We have a short survey that we'd like you to answer. I know not everybody's still on the call. Please do send us some feedback. It'll just help us pick topics that are relevant and useful to everybody. Thank you, everybody, for coming to this. We're going to keep this open for another minute or so you have a chance to do this. And hope to see you all at the next one. And thanks so much, Joe. That was really, really informative.
My pleasure. I'll stay online for a moment also.
Yes, sounds great.
Bye, guys. I really appreciate all of you coming. And I wish we had more time to talk together. I'd like to hear more about what you have to say sometime too. So bye for now.
Yes. Thank you, everybody. And we'll send you the survey link via email as well if you haven't had a chance to enter it right now.
Okay, bye.
Okay, bye-bye.
Does the survey come up, Soumya? I don't see it.
Yeah, the chat, she put this in the chat. I think this is the one.
Yes, I will reshare it now just because, yeah, I think it
just
got
did.
lost in the messages. Thank you.
Yeah.
Right.
Should we just wind up and